Hello, my name is David Greenwald. I'm fortunate to be the president of the American College of Gastroenterology and proud to represent the ACG at this superb international meeting, MIDTERM ENDOCON, with the Society of Gastrointestinal Endoscopy of India. What an honor and a thrill for me. I wish I were there with you all in person, but happy to participate virtually. I'd like to congratulate the organizing secretary, Dr. Manoj Kumar Sahu, and also the Society's current president, Dr. Matthew Phillip, who I had the pleasure of meeting in Kochi 2 years ago. I'd also like to congratulate Dr. Mahesh Goenka, current ACG governor from India, and Dr. Nalini Gouda. I was asked to speak to you today about the impact of COVID-19 on colonoscopy practice, and we'll do that with pleasure. In fact, I'd like to address several very important ways the COVID-19 pandemic has affected colonoscopy care. These will include endoscopic services and outpatient services, which impact the evaluation and scheduling of our procedures. I'd also like to touch on colonoscopic training and finish up with some words on vaccines. So let's start with where we are today, January 23rd. And in short, it's not good. Worldwide cases are just about to cross 100 million, and deaths that can be counted are greater than 2 million. The map shows worldwide distribution, with still significant red in both the United States and India, as well as much of Europe. Here's the closer look at the United States, also not good. Nearly 25 million cases and over 400,000 deaths. The distribution across the country is broad, and New York, where I work, remains with the most deaths, many of which came early on. And these are data on the 7-day moving average of new cases. The green line at the top, and unfortunately rising very steeply until recently, is the United States. India is shown in a darker green line with a peak in September and a steady decline since. So it's been just over a year now since we first heard about this novel coronavirus, pictured schematically in the upper right. In rapid sequence in January 2020, the virus was isolated, the genome sequenced, and then it was named. Parenthetically, vaccine development started almost immediately around that time. The clinical manifestations include diffuse pneumonia and were published in the New England Journal of Medicine in January. We learned very quickly about the transmissibility of this new SARS-CoV-2, which seemed to be similar to that of other SARS previous coronaviruses and greater than seasonal influenza virus. And we learned in real time each day as a seeming tsunami pictured on the lower left crashed into New York. We learned from our scientists and the lay press, like the New York Times pictured here, explaining spike proteins and ACE2 receptors to a public that was hungry for information about the cause of the coming pandemic. And we learned from the past. Here's a look at the 1918 flu pandemic and the value of measures like social distancing and mask wearing and how these simple tactics could have a great impact on mortality. So let's turn to COVID-19 and colonoscopy. Many studies and many data sets show a dramatic decline in endoscopic volume throughout the pandemic, with a very sharp drop at the outset. Indeed, an international survey of 250 centers worldwide by authors including Dr. Reddy, who gave the address before me this evening, showed an 83% reduction in endoscopic volume, and that was actually seen worldwide. Initially, much of that drop was a reflection of fear, well-founded fear, of course, and a lack of appropriate PPE. That same survey found that N95 use was less than 70% in much of Europe. Another study in the United Kingdom found procedure volume to be about 12% of pre-COVID volume, or put another way, a drop of about 88%. This drop in volume had and still has a profound effect on colonoscopy. As everyone around the globe struggled to figure out what to do, we collectively looked for leadership and guidance from our professional organizations, and they responded swiftly. Pictured here are guidelines from the European and American GI societies for endoscopic procedures, outlining which procedures were urgent and which could be delayed or deferred. Endoscopists around the globe could refer to these for guidance about their own procedures. Indeed, I'm proud to say that my regional GI society in New York, the NYSGE, proudly came out with its own very specific guidelines that greatly helped the community of gastroenterologists in New York that were hit so hard early in COVID-19. I'm also proud to say that emergent procedures never stopped, as they couldn't. And documents like this help to provide clear instructions for us on how to proceed. In the meantime, it was clear that for endoscopic services to continue, the PPE that we were relying on to keep us safe had to be shown to be effective. And by April, thanks to Dr. Ali Rapici and his colleagues in Italy, we had just that. In fact, the ACG was lucky to have Dr. Rapici speak to us early on and give us the experience that they had in Italy so we could feel better firsthand about what we were about to enter into. Dr. Rapici and colleagues published that data in April, showing that nearly 1,000 healthcare workers in 42 hospitals in northern Italy, only 4% developed COVID, less than 1% were hospitalized, and there were no deaths. It was clear also that most of the illness in healthcare workers came before the introduction of safety measures. And this was really great news. In short, properly worn PPE seemed to work against COVID-19 and still does. So how could one choose the appropriate level of PPE in a world that didn't seem to have unlimited PPE? And I'm very proud of the ACG here, as well as the other GI societies, for working on specific algorithms to guide decision-making. The ACG decision tree algorithm is pictured here and relies on knowing the relative community prevalence in a given area, recognizing that the risk changes as community prevalence changes, and also uses test results for COVID when available to help guide the proper level of PPE, thereby protecting healthcare workers appropriately while using relatively scarce PPE wisely. This algorithm was of great help to many clinicians around the United States, and I believe was used around the world as well. We also needed guidance about what to do when healthcare workers were exposed to COVID-19. And this is another algorithm from the CDC that depicts just that. One of the issues clearly important with how COVID-19 has affected endoscopic services and colonoscopy is by creating staff shortages when staff were sick or quarantined due to their own exposure. So guidance here suggests what to do in the cases of those exposures and allows healthcare workers to return to work safely when it's safe for them to do that. A few words about endoscopic training, which is a big issue in the fallout of COVID-19. In short, endoscopic training has been severely impacted by COVID-19, with a significant impact and reduction in hands-on training time. Our trainees in New York clearly are talking about it, and they are worried, and I think rightly so. It's unclear what the long-term impact will be, but consideration should be given perhaps for extra training time, or maybe a swap of some research time for extra hands-on time. There may be a role for increased use of simulators, although that's not exactly hands-on time. And certainly the pandemic has given rise to a massive increase in virtual education, much of which I don't think is going to go away anytime soon. Witness the ASGE president's fireside chats. Dr. Klaus Mergener has done these weekly, and they are excellent. And the very, very successful ACG Virtual Grand Rounds program, which has been equally well received. So let's turn to the effect of COVID on outpatient practice, which again was profound. This is the results of an ACG practice survey in 2020 in the United States, showing that in April, there was a 38% rate of office encounters as compared to the April the year before. There was only a partial rebound by June of 2020. Outpatient visits have remained well below levels of prior years as time has gone by, and it's anticipated that that trend will continue in the coming years. So what took its place was telemedicine. And I think telemedicine is likely to be here to stay. It's very convenient for many patients and for many providers, and allows a tremendous reduction in travel time for patients, many of whom are sick, and travel is quite a burden for. Telemedicine, however, is clearly fraught with a variety of problems as well. Important in these are technology issues, and I think really important is that not everyone has access to the needed technology, which raises issues of worsening equity and access to care around the United States and around the globe. As someone who witnessed firsthand the inpatient surge in March, April, and May in New York, I want to say a few words to this group about isolation and fear. They are both very real and have profound effects. COVID patients were isolated and are isolated in the hospital, and those who died, many of them died alone. Their families were not allowed to be able to visit and help them. This was really difficult for the patients and really difficult for the families. We used technology as much as we could, iPads, video phones, but it doesn't really replace being together. Physicians are also isolated from their patients, and that's a big deal. Physicians were isolated from their patients because of a fear of COVID, which is real. They're also isolated from their patients because of the use of PPE, which protects the physicians and the patients. Using masks, shields, gowns, and gloves really puts up an extra barrier between patients and providers, and really changes the interaction in many settings between the patient and that provider. There is clearly a loss of touch when you're wearing multiple layers of garb between you and the patient. And finally, recognizing the stress and anxiety of everyone is critical, and meeting it head on is really, really important. Rates of worsening mental illness, worsening depression, and increased levels of suicide in healthcare workers have been reported throughout the pandemic and should have, unfortunately, lasting impact. Staff burnout is also real. It's hard and exhausting to work in PPE all day. I've already mentioned staffing issues as staff or families get ill and the staff needs to be quarantined, and these affect your ability to perform endoscopic procedures. Working from home has certainly become a thing, and managing the work-life equilibrium is equally challenging for many folks. In the end, great communication is central to helping with this. Open dialogue with other professionals about what their stress is about is critical to helping each other, and it's been so important throughout the pandemic. Yes, keep helping each other is really key. I want to speak a little bit about mentoring and coaching as well, and something that I've termed avoiding the COVID leadership vacuum. It's very easy to retreat into isolation, into an office, but it's really important if you are running an endoscopy practice, an office practice, to reach out regularly to everybody who's working with you and make sure that you're all having staff meetings by phone or video platform so that you see each other and you feel that sense of connection. So let's turn to colorectal cancer screening during the pandemic. The chart on the left is from the American Cancer Society and the National Colorectal Cancer Roundtable in the United States. It shows a greater than 90% drop in colonoscopies in mid-April as compared to the same period in 2019. The American Cancer Society estimated that that translates into almost 19,000 missed or delayed diagnoses of colorectal cancer during the 3-month period between March and June of 2020. Also recognized that there were 1.7 missed colonoscopies in the United States during that time, and they've calculated that there will be 4,500 or more excess deaths from colorectal cancer over the next decade due to the pause that occurred because of the initial wave of COVID. I believe that these data are an underestimate of the problem at this point, because we know that more months have ensued where colonoscopies have been deferred. And so I think these estimates actually will only be magnified. So here's the American Cancer Society's marketing materials and press releases highlighting 3 major points to making a successful return. And these resonate with the public. Don't postpone regular care, resume regular health care, and there's a cost in healthcare quality to missing screening activities. We've made great advances both in the United States and worldwide in colorectal cancer screening and prevention, and the pandemic threatens to undo a lot of that And it's important for us to think about successful ways to market that return. At Mount Sinai in New York, this is part of what we did. We made a video to reassure our patients who were coming in for procedures about the processes that were being followed both before they came for the procedure, during the procedure, and after the procedure. And finally, let's turn to vaccines. What I want to highlight here is the rapid development of vaccines. As I mentioned at the beginning, vaccine development began almost immediately after the virus was sequenced. In a fairly remarkable turn of events, in something just short of a year, vaccine trials began, were completed, and in the United States now, 2 vaccines have achieved emergency use authorization. In other parts of the world, other vaccines are being used as well. So pictured here are the types of vaccines that are available right now. The 2 in the United States that have been granted emergency use authorization are mRNA vaccines that are depicted on the left. The next 2 that are likely to be approved in the United States are viral vector vaccines, adenovirus platform vaccines, and there are also protein vaccines, inactivated SARS-2 virus vaccines that may become available in the United States and are available in other parts of the world. So how well do these vaccines work? Well, they actually work really well. So in the 2 candidate vaccines in the United States, the trials that were completed, vaccine efficacy was 95% in both of the trials. Of note, in the Pfizer vaccine trial, efficacy was over 94% in the subgroup that was 65 years of age and over. I think equally important is in the Moderna trial, the efficacy of the vaccine against severe disease was 100%. There were no patients in the vaccine group who developed severe COVID, that being defined as requiring hospitalization, intubation, or dying. But there's still a lot we don't know about vaccines. I think these are the key questions that we'll have to answer over time. What's the safety and efficacy of these vaccines over time? Are they safe and efficacious in children because the clinical trials were not done in people of that age as yet? What's the situation in pregnant women and for immunocompromised patients? Importantly, will the vaccine protect us against asymptomatic infection and the ability to transmit the virus to unvaccinated patients? That's a very important question as vaccine availability continues to expand around the world. Another unanswered question would be what happens if the second dose of the vaccine is missed? And finally, I think the effects of vaccine hesitancy are real and very significant. I've been fortunate to speak to patients all throughout the last few weeks about their concerns and fears about the vaccine. And I think it's one of our responsibility to provide accurate information to anybody who we come into contact with. The GI societies came together to write about the importance of speaking to our patients, our colleagues, our families, and our friends about the importance of understanding the accurate information related to vaccination against SARS-CoV-2 and to make their own decisions with all the information that is there. It's estimated that in the United States, 70 to 80% of the population needs to be vaccinated in order to achieve herd immunity. And we need to get past significant mistrust and vaccine hesitancy amongst the population to get there. So vaccine distribution has begun. These are pictures of my first 2 vaccines, or my 2 vaccines, 3 weeks apart. In total, as of this morning, almost 20 million people have received at least 1 dose of a COVID-19 vaccine in the United States, and 60 million people have received at least 1 dose of a COVID vaccine worldwide. Another really bright spot in an otherwise dark pandemic has been the collaboration of the GI societies. And what you see pictured here are multiple communications where the societies came together to talk about important issues related to the COVID-19 pandemic and getting information out to our members. These alerts are shared both nationally and worldwide, and really proud of the collaboration that has occurred through the past year. And I really thank my colleagues in the other societies for stepping up to the plate and working on these collaborative efforts together. So to sum up, what's the impact of COVID-19 on colonoscopy practice? Well, I think it's pretty clear that the practice of gastroenterology and gastrointestinal endoscopy has changed dramatically over the past year. And I believe, as many of you do, I'm sure, that many of these changes are likely to persist for quite a while to come. All the while, the scientific breakthroughs that we've discussed about treatments for COVID and ultimately the vaccine development have been rapid and they've been profound. I don't think the impact of COVID-19 on GI or endoscopy will be known fully for quite a while. We've found for sure that we are resilient and creative in solving problems. And I think with the isolation that I spoke about, the value of connections, collaborations, and camaraderie has never been more important. So with that, I leave you with one of my favorite images of the past year, a piece of art showing Superman in his cape, saluting the heroes of the year, the true heroes of the year in my mind, the many, many healthcare heroes. I'd again like to thank the organizers for inviting me on behalf of the American College of Gastroenterology, and thank you for your attention.
Thank you, Professor David, for taking us through the impact of COVID-19 in the practice during of colonoscopy. So it's been a wonderful talk. Yes, a lot of innovations have happened during this period. That is the positive side. But at the same time, we must have lost out on a number of colonic cancers since the colonoscopy wasn't being done at the optimum what it should have been done. So I can invite some questions. I would like those to be done. I have two questions. During the COVID time, has the capsule colonoscopic procedures had they increased or not? And what would have been the role of water-assisted colonoscopy, which is faster, for anyone wanting to do during this period?
Because it is not of capsule endoscopy or any procedure. It's actually patients scared to come to hospital. So that is actually the biggest problem. Only emergency cases were coming in between. And later, then gradually we ourselves actually spacing our procedures also. All non-urgent procedures are actually given dates, and only emergency procedures are done initially. Then gradually we reduced all these restrictions, and now it is coming up. And now it is almost, for us, is almost the same, back to our normal one. But still, then Kerala, still we have a lot of COVID cases. Our capsule numbers have not gone up during COVID time.
Right. But do you think it could have gone up? You have very rightly said that patients did not want to come to the hospitals. But some home related procedures or tele thing.
The only
just a wild thought.
No. The one thing which has really improved or increased, which was not there, was actually the usage of telemedicine by normal people.
That's right.
And even our OPD, everything, is one consultant was sitting totally for telemedicine, and patient, and probably people think that it is legalized also. So that was actually one good thing that came up.
Right. That's right. Okay. Thank you very much. I thank the organizers. Thank you, Dr. Matthew.
Yeah,
thank you.